Hi, everybody. My name is Cherise Santos, and I am Care Services Coordinator for the ALS Association Greater New York Chapter. It's so nice to have you on here. I want to introduce Esther Kane, who is a Director of Support and Education for the Association for Frontotemporal Degeneration, located in New Jersey. She received her master's degree in nursing from Wilmington University. If you have any questions after the or during the session, please put them in the Q&A and we will get to them at the end. Thank you.
All right, thank you so much, Cherise, for introducing me today. Let me see if I can pull up my slides.
Oh, we're not live yet, I don't think.
Oh, no.
We're live.
Okay. Hi.
Okay, that's okay. Let's pull up our slides. That's wonderful. Great. Can everyone see my slides? We're good, Cherise? Good.
Yes.
Wonderful. Good afternoon, everyone, and thank you for allowing me to come and talk to you a little bit about the FTD and an FTD-ALS diagnosis. My name is Esther Kane, and I am a registered nurse who has spent most of my career working with people with dementia in clinical settings. I am AFTD's Director of Support and Education, and I unfortunately have a personal relationship with ALS with a professional relationship in FTD. So the story of FTD-ALS is one that rings very true to me, and hopefully we'll be able to dive in a little bit more to some of the behaviors that are associated with FTD and how that affects an ALS diagnosis. So my goal today is to broaden your understanding of FTD and what that diagnosis is, to describe common FTD symptoms and an FTD-ALS diagnosis, to review ways to manage symptoms and be able to care for people as long as you can at home, and to consider some of the unique struggles families face with an FTD-ALS diagnosis. So what is FTD? FTD represents a group of brain disorders caused by degeneration of the frontal and or temporal lobes of the brain. FTD is also frequently referred to as frontotemporal dementia, frontotemporal lobar degeneration, or Pick's disease. It is the most common dementia for people under 60, with the majority of people diagnosed between 45 to 64 years. This age group is often still physically active. They have fewer other health issues and are actively involved in work and family life. Unlike Alzheimer's, memory loss is not the primary symptom, and many people with FTD do not experience any memory loss at all. FTD initially impacts behavior, language, and movement in many cases. It's less common than some of the other dementias, but still very, very prevalent. And for all these reasons, the younger age of onset, the range of symptoms that it can present, and the rarity of it, FTD is underdiagnosed or initially misdiagnosed. And many people, even with an FTD-ALS diagnosis, may have gotten a ALS diagnosis, but struggled to understand some of the FTD symptoms that were occurring. And we're going to talk more about that as we go through this presentation. So FTD is a spectrum of diseases. Frontotemporal degeneration is an umbrella term for a range of disorders that impact the frontal and temporal lobes of the brain. The FTD spectrum ranges from progressive supranacular palsy, which is more of a movement condition, to behavioral variant FTD. The subtype of FTD you are diagnosed with can be identified according to the symptoms that appear first and most prominently, whether in behavior, as we see in behavioral variant FTD, changes in the ability to speak and understand language, as we see in primary progressive aphasia, or in movement, as seen in corticobasal syndrome. The clinical, it all varies based on what people are diagnosed with and what symptoms they demonstrate first. The clinical syndrome, where FTD and ALS occur in the same person, is referred to as ALS Frontotemporal Spectrum Disorder. Over the last 10 years, there has been an increasing recognition of a continuum between ALS and frontotemporal degeneration. Up to half of people with ALS also show symptoms of FTD, while up to 30% of people diagnosed with FTD develop motor symptoms consistent with ALS. People diagnosed with either ALS or frontotemporal degeneration may feel overwhelmed by their situation and miss or overlook possible signs of the other syndrome. But a potential dual diagnosis is important to consider due to its impact on treatment, prognosis, understanding the genetic risk involved. Diagnosing cognitive and behavioral impairment in ALS requires a comprehensive neuropsychological evaluation. And this testing should really look at language skills, memory, executive function, visuospatial abilities, social cognition, and behavior screening. The evaluation should include standardized measures that allow for appropriate control of writing and speech impairments the patient with ALS may have. Strong's criteria for diagnosis is the gold standard to identify ALS FTD. And in order to be diagnosed, they want to see a progressive deterioration of behavior and/or cognition, and in addition, presence of at least 3 behavioral cognitive changes associated with behavioral variant FTD. And I'm going to talk more about behavioral variant FTD and these symptoms in a few slides. Or they want to see at least 2 behavioral cognitive changes associated with bvFTD together with loss of insight. And we're going to talk more about loss of insight and what that means. Or fulfilled criteria for primary progressive aphasia. Research into the causes and genetics of FTD is a very active area of focus in the field because many people with FTD are underdiagnosed or incorrectly diagnosed. Exact data is not yet possible. Multiple studies since 2009 have identified that approximately 40% of people with FTD have a family history of some type of dementia, a major psychiatric condition, or progressive changes in movement. A subset of familial FTD cases are caused by a change or mutation in a single gene that was inherited from a parent. All known genetic forms of FTD are autosomal dominant, meaning that if one parent has an FTD-associated variant, the child has a 50% chance of inheriting it. While the majority of genetic FTD is caused by 3 genes, C9orf72, which we're going to talk more about in a little bit, GRN and MAPT, at least 9 more very rare variants are known to cause FTD, and more may be discovered. In most people, though, diagnosed, FTD is a sporadic condition. There is no known family history of dementia or neurodegenerative disease. With a sporadic case of FTD, the risk of other family members developing FTD is no more or less than anyone else in the general population. Sorry. So C9orf72, the discovery in 2011 that the C9orf72 gene mutation can cause FTD and ALS has transformed a long-held belief that ALS is purely a neuromuscular disorder and that FTD is purely a cognitive or behavioral form of dementia. It is now recognized that the C9orf72 gene is the most common gene causing heredity. FTD, ALS, and ALS with FTD. We also know that several other genes can cause both diseases. Researchers are still learning about FTD-ALS, and there are many questions we still do not know the answer to. When we talk about FTD, it's important that we really understand what's happening in the brain because it helps us better understand what's happening to the person. The specific symptoms a person displays are determined by where in the brain the disease starts. So in the frontal lobe of the brain, this area controls our reasoning, our decision-making, it controls our behavior, our problem-solving skills, our attention and concentration, our emotional control, our safety awareness, our initiation planning. It controls so much more than I think we give our brain ever credit for controlling. And because of this, when we see damage to parts of the frontal lobe, we see some of these behaviors that are evident in behavioral variant FTD. bvFTD is the most common FTD disorder. We commonly call it bvFTD. So you're going to hear me refer to behavioral variant FTD as bvFTD quite often. It is responsible for about half of all cases. It's hallmarked by noticeable change in personality, behaviors, and judgment. People diagnosed are often described as acting strangely or inappropriately. The changes sometimes can be very nuanced and small, resulting in sometimes embarrassing and awkward social situations. Often there is a lack of insight by the person, and we're going to talk more about that in a little bit. They may not recognize their behavior has changed or care that their behavior is unusual or even realize what's going on. These changes in behavior is very often a dramatic and very different from the person's historical baseline, which is very often why bvFTD can be misdiagnosed in the beginning as depression or other psychiatric conditions. The 6 most common symptoms we see in bvFTD are apathy, which we're going to talk more about, behavioral disinhibition, we're going to talk about that too, loss of sympathy or empathy, compulsive ritualistic behavior, changes in eating habits or diet, and deficits in executive functioning. Apathy and FTD can be present at all stages of the disease. And I think it's really important here to note that apathy can be present in FTD and ALS. So it's not specific to just an FTD diagnosis. And it's not just specific to an ALS diagnosis. And you're most likely to have it with an FTD-ALS diagnosis. Apathy is, you just no longer want to do the things that you used to do. You kind of lose that drive to engage in ways that you used to want to engage, which is often why it's misdiagnosed as depression. The person with FTD may know that what they want to do, but have trouble carrying it out due to impairment in initiation, planning, and motivation. All functions that are supported by our frontal lobe. Apathy can present with a loss of interest in work, hobbies, and personal relationships, neglect of personal hygiene, the person who no longer showers or shaves or is taking care of themselves, or a loss of initiative. And in addition, a failure to complete tasks that used to be easy for them to complete. Apathy can be one of the most challenging symptoms for family and professional caregivers to manage. Effective interventions are individually tailored, rely on environmental strategies, and are delivered with understanding and patience. Initiation is the inability to self-generate or activate actions or thoughts, so they have difficulty beginning a task. When caring for someone who has issues with initiating, we want to consider a few things. Maybe consider using external cues. Are there other things in the environment that we can use to cue them to begin a task? We want to keep tasks simple because the simpler the task is, the easier it might be for them to tackle it or take it on. We want to post reminders or set alarms on the smartphone. It's really common. I hear from a lot of families in the FTD space where they will use the smartphone to remind people to, okay, now it's time to get up and eat lunch, or now it's time for the next activity, and this is the time we brush our teeth. Routine can help a lot with this too, and helping the person with FTD or with some of these behavioral symptoms be able to manage their day-to-day tasks. You want to present cues through multiple senses, including visual, auditory, tactile, and you want to really consider even things like putting something just in somebody's hand. You know, if you take a broom and put it in somebody's hand, they may start sweeping the floor. But saying, please go sweep the floor, they may not be able to start that task. Sometimes too, we recommend starting an activity side by side. So if you are trying to help somebody with brushing their teeth and they won't brush their teeth, maybe just take the toothbrush and put some toothpaste on it and start with them. And then you may see that they'll start to brush their own teeth and be able to finish the task on their own. You know, it's important that we can maintain independence for as long as the person's able to maintain independence. And in FTD-ALS, some of these things may become more of an issue as some of the physical pieces of an ALS diagnosis start to take hold on top of the cognitive. And we're going to talk more about that in a little bit. So you really have to be individualized to the person and what their skills are. No one intervention is going to be able to meet the needs of every person. But if you're aware of a couple different ways of trying something, usually you can find something that might work with the person that you're helping to care for. Another issue we see very often is this impaired planning. So plans of action are complex in nature and often involve multiple mental steps. So when a task has too many steps, somebody with apathy struggles with completing all the steps associated with it. So if you want to, sometimes shrinking down the steps and making the process simpler can help the person with apathy be able to tackle it. So for example, limit the choices. Why don't you lay the clothes out on the bed for them with the shirt and the pants right there so they don't have to go looking for where the clothes are in order to get dressed. Consider things like with less buttons and zippers and multiple tasks considered in dressing. Pull on clothes, they tend to do better with that, and it's easier for them to manage on their own and more independently. And then with lack of motivation, which is very often seen, motivation is based partly on the process of reward information in our brain. And when that trigger isn't being set off, people just don't have the desire to do anything or to perform any task. And so we want to try to encourage them where we can encourage them and where maybe we can still spark a little motivation. Turn off the TV or radio to reduce competing stimuli or things that might be trying to distract the person. You want to provide praise and positive verbal feedback, acknowledging the actions they are taking in the right direction. And then maybe offer a sweet or chewing gum or something else that they like, ice cream or another treat in order to complete a task. I've told many a family, sometimes even just you can't get somebody to the doctor, they won't go to the doctor, they're not in the mood, they can't get motivated. If you can find something that they like to do and make that more the focus of the task, you may be able to get them to get to the doctor so that they can then get the reward thing that they want, like going out for ice cream or coffee or their favorite diner for dinner. And very often families tell me that it's a very successful intervention. Anosognosia is the inability to recognize or perceive one's illness and limitations. This is a hallmark feature of behavioral variant FTD. And as you could see on the Strong's diagnostic criteria, it was an identifying feature of bvFTD. It's not uncommon for people with FTD to not recognize that they have the illness. And this is an extremely demanding issue for families and symptom for families to manage. Even those who acknowledge they have a brain disorder may deny they are upset or worried about their condition. Anosognosia is one of the main reasons people with FTD refuse medication and medical and personal care. People with this lack of insight may be able to function normally in some areas of their lives, yet demonstrate risky behavior elsewhere because they do not recognize their limitations. It is important to ensure that the family care partner receives FTD education and support. The more that care partners understand that this is a symptom of the disease, the easier they can address the situation. You want to avoid power struggles and angry escalations. This isn't a purposeful act. This is part of the disease process and the way the disease affects the brain, causing people to have an inability to recognize their illness. And power struggles will just escalate into often very aggressive situations. What may be experienced as the person lying or not admitting to the disease is just a symptom of the diagnosis. So don't try to reason with the person or contradict their own assessment of their health or abilities. If they say they're fine, trying to convince them that they do have a disease is not going to help them or you in the process. You want to discuss issues and plans only at the last minute. When you need your loved one to do something, you may need to sell it rather than present the request forthrightly. And we tell people often that, sometimes you may have to sell a few little white lies in the best interest of the person that you're caring for, especially when safety concerns are there. Now, I say this in the sense that it's not always the best practice and we do not want to be lying to people. So, you really have to evaluate the situation and determine what is best for the person and evaluate the safety. Executive function skills are defined as planning, judgment, reasoning, problem solving, organization, attention. Think of any task that you complete on a regular basis, and that usually requires quite a bit of executive functioning skills. People with FTD, very often, they have impaired executive functioning. They start to miss little details or tasks or parts of these planning activities. And these are very often some of the first triggers to families that something is seriously wrong. Dad stopped paying his bills, or mom was found walking in the street and she didn't have shoes on. It was so out of character and it wasn't a normal behavior for them. And this really triggers a realization that something else is going on and they require further testing. In these areas, people are really prone to financial scams, frequent scratches to their car, missed appointments, bouncing checks, poor judgment. And all of these things make us have to think about safety and really consider, is the person safe? And what do we have to do to promote their safety and their independence? When a person has impaired executive functioning, we have to look at, are they safe to live alone? What measures can be put in place to maintain their independence? Are they safe to be able to live in the environment that they're in? What supports do we need to put into place for them to be home alone even? Maybe they don't live alone, but there's times they're home alone. Are they safe to be home alone? Are they safe to drive? You may want to pursue driving cessation. I know that's very hard, and it's very hard to take away somebody's independence, but we want to make sure that we are providing safe environments for the community, as well as for family and friends and for your loved one. People with impaired awareness and judgment should no longer be driving, and it's an obstacle to overcome. Can they manage their finances? Have they set up a power of attorney? And we're going to talk more about these things in a little while. But sometimes doing things like giving them a credit card with a small amount of funds on it is a way to let them still have some independence, but allows the caregiver to put some barriers around the finances. It is not uncommon for us to hear of people having had given $50,000 to somebody in another country who was a lost prince in need. And people with FTD are very prone to these types of scams. We've heard of people taking pictures of credit cards and sending them online to different people and losing thousands of dollars. So when you can limit that interaction with those types of funds, but still give them the independence maybe of having a card with a small amount of money on it, it's a good way to kind of maintain who they are and what they want to do, but still keep the finances safe, which is always an area of concern. You also want to think about the home. Is the home safe? Can I bring in people to come look at the house? Do I need adaptive equipment? Do we need to move where the bedroom is? Do I want to consider putting a ring on the front door? Because they're prone to sometimes leave the house when they're not supposed to. And this way I'll know. So no person is the same, and not every person needs to go through all of these steps. But for every person diagnosed, there's usually a couple of these that need to be considered and thought about. And in different stages in the disease and the diagnostic process, we need to look at whether or not they're safe and the environment's safe. Unfortunately, with FTD2, we want to be careful of, if there's kids in the home and if there's kids around people with FTD, especially when disinhibition is present. And we're going to talk more about that in a little bit. So what is disinhibition? So disinhibition is a loss or lack of restraint based on social norms. It's leading to inappropriate behavior and impulsivity. So this is like making uncharacteristic, rude, or offensive comments. You may be at a restaurant eating dinner, and the person diagnosed may say, "Wow, they're really fat," to the waitress. And everyone might be appalled that would come out of their mouth. And that may have been something they would have never said before. But the ability for the brain to kind of inhibit it and realize what's appropriate and what's not appropriate to say is no longer working or functioning the same way. And so we see a lot of those types of comments. You'll see people who don't respect personal space. They kind of walk into other people's personal space. They may hug a stranger or hug a person that they don't normally know, and this leads to more issues and areas of really embarrassment for the family. So what do we want to do? We want to manage expectations. The stigma associated with dementia or FTD can be very difficult for caregivers. And very often when I talk to them, and I'm talking to families even on our helpline, what we're seeing is that they're struggling with the way that the new behaviors are changing their life. And it's changing the way they interact with other people, and it's changing the way other people view them and their spouse. And I think the most important thing here to recognize is that this is the disease. It's not the person. The person hasn't changed, but the disease has changed how the person reacts and responds to things. And the more we can make that separation, the more we're able to really recognize what's going on and see that it's a person who's struggling with some behaviors or some issues due to degeneration that's occurring in their brain. The behavior is not on purpose. AFTD has these lovely awareness cards. We give them to families all the time, and we ask them to share. Let people know what's going on. Explain to them that the person diagnosed has a neurodegenerative disease, and this disease is causing them to maybe blurt out inappropriate things, or it may be affecting their language or their communication skills. The more we can notify people and engage the community in what's going on, the more we can erase some of the stigma that comes along with the dementia diagnosis. And we can allow people to be treated with more respect and dignity and cared for, which can be very difficult when it's dealing with issues of the brain and behaviors. So what do we want to do? We want to modify the environment. We can't modify the person. The person has no control over their behavior or why they're behaving the way they are, or why they're doing what they're doing. But we can modify what's happening in the environment. I had a person diagnosed who I was speaking with, and she was telling me how she had children in marching band, and she wanted to go to as many marching band activities as she possibly could. She wanted to have every moment with her kids that she could have. But the noise was really bothersome to her. She felt very claustrophobic. She really struggled with the environment. And so what her and her husband did is they got her headphones that she would bring to every game that she could wear to help minimize some of the external noises. She would park right at the exit, so she knew exactly how to get out as soon as she was done with the marching band piece of the event. She would sit in as quiet of an area as she could to be able to really engage in the activity. And that's what modifying the environment is. It's how can we adapt the environment to make the person diagnosed be more successful. I've seen a lot of people too maybe choose to go to a restaurant at 3 p.m. when it's quieter and it's not as busy, and the person can be more successful to be able to go and enjoy a meal. Whereas if you try to go during dinner time when there's a wait list and there's too many people in the environment and it's very loud and noisy, the person with a dementia diagnosis is not going to be successful. So one of the things we want to consider is just control what you can control and let go of what you can't control. There's that old saying, God give me the grace to accept the things I cannot change and courage to change the things I can. And I think this is a good place for that type of sentiment. So it was originally believed that bvFTD was the most common FTD diagnosis in a FTD-ALS diagnosis, but more and more people are presenting with the language subtypes, or what we call primary progressive aphasia. And we're seeing this a lot with some of the language deficits associated with an FTD disorder. PPA we end up seeing PPA from damage to the temporal lobes. And our temporal lobes actually control quite a bit. They control our inhibition of speech, our visual memory, pictures, shapes, and faces, how we view art, and how we interpret that information in our brains. So primary progressive aphasia is characterized by progressive loss of oral and written language skills. Comprehension and language expression may be affected. And I think the thing I want to really get across here is that when somebody has language deficits, sometimes some of their behaviors are just due to their frustration and their inability to communicate. And so the more we can give people tools to be able to communicate, Sometimes some of the agitation or aggression may be diminished because we're giving them their voice back a little bit. And sometimes we have to be creative about that. And we're going to talk more about that in a few minutes. But PPA has three main subtypes that we see very often in FTD. The non-affluent version of it, where individuals begin to lose proper grammar, especially their ability to use small connecting words, but have preserved language comprehension for specific items and objects. This causes speech to become effortful and hesitant, and sentence length becomes progressively shorter or truncated. Writing and language comprehension may be affected in the same manner. The semantic variant is primarily a loss of word meaning or anomia. So here the meaning of specific words is lost, and both comprehension of the word and the ability to retrieve the name of an object may be lost. Difficulty reading or writing words that don't follow pronunciation or spelling rules. And we see a lot of word substitution in semantic. In logopedic PPA, speech is slow, but grammar and comprehension are less affected. A person may lose the ability to repeat phrases or sentences, and sound substitutions are also seen. So how can we better understand the person diagnosed when they're trying to communicate with us? Well, we want to encourage nonverbal communication strategies, pens and papers, whiteboards, anything they can draw on to maybe try and help us understand what they're trying to communicate. We want to ask for clarification if a response is incomplete or unclear. And we want to use all modalities to support communication: pictures, props, gestures, actual items to show them, this, did you want a pen? Is this what you needed? And sometimes that will help click that information in and help them be able to communicate. You also want to give them time and space. Oops, sorry. Went through all my slides there. We also want to give them time and space and let them know that it's okay to take their time to communicate. And sometimes by just allowing the piece of the conversation to occur, the person is then able to find their words. The anxiety and the stress of trying to communicate can make communication even more difficult. And the more we can be calm and quiet and give them space and say things like, it's okay, take your time, I have time, it'll allow the person to be able to communicate what it is they're trying to communicate better. When they have difficulty understanding you, we want to take some other options. You want to take them to a quiet, undistracted place where you can sit and really communicate. You want to look face to face and be able to tell them exactly what you want to communicate, and let them be able to see your verbiage and see how your facial expression is and everything else they can read to help them understand what it is you're trying to communicate. You also want to use different techniques and whatever needs to be done: cueing, clarifying meaning, describing the word, and then use shorter sentences. Simple is usually better. So as you can imagine, balancing an FTD and an ALS diagnosis at the same time is a balancing act for caregivers and for people diagnosed. Early detection and careful monitoring of cognitive deficits in ALS are crucial for patient and caregiver support and to enable personalized management of individual patient needs. You want to discuss with the individual their wishes regarding whether or not they want feeding tubes or ventilators. What goals of care do they have? And when you're dealing with cognitive impairment, we want to have these discussions as early as we can, while the person may still be able to make some decisions for themselves while they can. FTD's cognitive impairment complicates these decisions as the disease progresses. We want to have complete key documents, power of attorney, end of life wishes, all of those things. You always want to seek support from an ALS association clinic for a team approach to care and adaptive equipment related to the muscle disorder. You also want to inform all members of the care team that treatment decisions must include the caregiver, healthcare provider, or power of attorney due to the individual's cognitive impairment, and make sure everyone's aware as to what's going on. You want to think through recommended ALS interventions in light of the FTD diagnosis. A person with dementia may not understand how to use adaptive equipment and/or lack judgment to use it safely. You want to work with your care team to see what solutions can we come up with that are going to work the best for this particular individual. And remember that every person is a particular individual and their needs are unique to them. So where one patient may not be successful with something or one person may not be successful, doesn't mean that all people with an FTD-ALS diagnosis won't be successful. So really try to understand where the weaknesses and strengths are and try to work within them. You want to bring in a care team, and we're going to talk more about that in a little bit. And that's something that the ALS Association and the clinics, they do a great job of, making sure that you have these supportive therapies and services in place and can easily access them to make sure that you're getting really comprehensive care and as many interventions in as possible. You always want to consult a speech language pathologist because we want to look at how can we help these people better communicate. Are there swallowing issues? What else is arising? And this is true in ALS as well as FTD. The speech language pathologist can be a great asset to the family and to the caregiver and the person diagnosed. So managing the unique needs of FTD and ALS can be a tug of war for families and create unique obstacles and barriers. Caregiver burden among FTD-ALS patients is high when the behavioral and physical demands are high. Supporting the caregiver needs to be part of how healthcare professionals care for these patients. The tug of war and need to balance the behavioral and physical symptoms of an FTD-ALS diagnosis can lead to a decreased life expectancy than can be seen in just an ALS or FTD separately. Since FTD has no FDA-approved treatment, caring for a person with FTD requires a team approach to manage the complex, ever-changing symptoms a person experiences. Care teams can consist of family, friends, and community support, a medical team, social workers, therapists, speech and occupational therapists, elder law, palliative care, and hospice. It's whoever you need on your team to help you be able to optimize the quality of life of the individual and be able to support the caregiver. For both the person with FTD and the care partner, having others involved in providing care and making difficult care decisions is key and very supportive. Very often the caregivers just don't know what to do next. A big key to supporting caregivers is through support groups. I know the ALS Association and AFTD have many support groups that are available. And support groups provide a resource, an outlet, and a place to collect and share your thoughts. Very often I hear from families with an FTD diagnosis how important it was for them to engage with a support group and be able to talk to people that really understood where they were at and what they were dealing with. AFTD also has an FTD-ALS specific support group. It's a national support group. It's done via phone. And if you're interested in something like that, please feel free to reach out to the helpline. And we're going to talk more about that in a little bit. FTD-ALS is highly genetic. Individuals and families who are concerned about a genetic disease may benefit from a genetic consultation, regardless of whether testing is available or desired. Many people seek information and coping strategies as much as test results. Genetic counseling does not always mean genetic testing. And uncertainty of genetic status can lead to increased stress and anxiety on families. If you have questions about your genetic status or questions about how to move forward or what to do, see a genetic counselor. They are a great asset to so many families. And remember, just because you see the genetic counselor does not mean you need to pursue genetic testing. The FTD Disorders Registry, co-founded by AFTD and the Blue Field Project to Cure FTD, offers a powerful way to advance the science of FTD research. Information about the registry can be found at ftddisordersregistry.org. Many people affected by FTD find that participating in research helps them to draw meaning to a disease that could bring so much personal devastation. There are a number of research opportunities for people with both FTD and ALS related to C9orf72 genetic variants. FTD clinical trials currently recruiting participants with C9orf72 variants are included here. And there's quite a few that are coming out right now specifically for this genetic variant. So here's some additional resources for you. The Association for Frontotemporal Degeneration. Our mission is to improve the quality of life of people affected by FTD and drive research to a cure. We work every day to advance and promote research toward diagnosis and treatment, stimulate greater public awareness and understanding, provide information and support, promote and provide education for healthcare professionals, and advocate for research and appropriate affordable services. AFTD is here to help. No one needs to face an FTD diagnosis alone. We offer a number of informative newsletters and publications. You can register through AFTD's homepage on the website to begin receiving the newsletters or to order the publications. We also have a ComStat grant program, which offers respite grants up to $500 for caregivers who live with a loved one with FTD, travel grants for attending our education conference, which we hold every year, and quality of life grants, which help those diagnosed with an FTD diagnosis to access services or supports that improve their quality of life. In addition to the many support groups and other things that we have on our website. For medical professionals, we have a number of resources that can help medical clinicians and care professionals to better support those with FTD. We have a Partners in FTD Care publication, which comes out with interesting topics, whether it be disease specific, challenging symptoms, or common problems or concerns. Sorry. We also have webinars and presentations on our site. And please feel free to reach out to the helpline at any time if you come up with struggling situations and don't know how to proceed. And now I am going to open it up to some questions.
Hi, everybody. If you have any questions, please put them in the Q&A. Esther, there is a question, where is the genetic testing done and when should that be looked into?
It should be looked into whenever you feel comfortable and you're ready to address it. So, I think every family is very different and everyone's needs is very different. And it's important that you do what works best for your family and you do what works best for you. We've had people who want genetic testing the minute they're diagnosed, and we have people who need to wait and process and kind of go through that process and figure out what works best for them and what information that they need. Genetic testing can be ordered through your doctor. They can order the genetic testing. Most clinics do have a neurogeneticist available to be able to interpret and talk to you guys about what genetic testing is being done and the complications and things that you want to consider in the process. There is also free sponsored genetic testing. And if you go to the AFTD webpage, we have a whole, a lot of information about different ways that you can engage in genetic testing.
Okay. And what are your thoughts on someone attending an adult daycare program, or is it better to be at home?
I think every person's really different. So, and every family situation is very different. I've heard great success stories with adult daycares where it gives the caregiver a little bit of a respite and a break, especially medical adult daycares that are set up to manage some of the physical needs or behaviors that are occurring. And usually it all comes down to education. They may not be aware that the person is younger. They may be younger than some of their other clients. They may be more physically able than some of their other clients that may not be more physically able, especially if we're dealing with an actual FTD-ALS diagnosis here, where physically they may be needing more help also. So, it's really knowing the person and knowing how well the adult daycare is going to be able to personalize the care towards that person. But I've heard wonderful stories of families where adult daycares had people build gardens in their centers, and they really used their strengths to be able to get them involved and do things. And the caregivers really got the break and respite that they needed.
Okay, great. Thanks. And one more question here. Does do Alzheimer's medications help?
Unfortunately, there hasn't been much research in this particular space, but the research that has been done in the FTD space does not typically recommend Alzheimer's medications. It has to do with what those medications are designed to attack, and that's not what's occurring in FTD. So, really talk to your doctor. We have a lot of information on our website about medication management in FTD and understanding what works and doesn't work. Very often, though, these medications can make the person actually more agitated and does not help the way that people hope that it will help.
Okay. There's a question in the chat. At what age approximate can I feel that I'm past the age of possibly being afflicted with FTD?
I don't know if there's ever an age where you can feel like you're past the age. I think it depends on the person and the situation. If it's a genetic situation and you feel like there's a possibility that you might have it and you're kind of waiting it out, every person's different and every situation's different. If you have real questions about it and want to get more information, I recommend that you reach out to a genetic counselor to talk more to them about what your actual risk is of developing FTD and what that might look like.
Okay, and there are two questions on Whova, not here, about support groups. You said that there are support groups for FTD and ALS families. That's through the association?
Yeah, so the Association for Frontotemporal Degeneration has a support group for caregivers with a specific FTD-ALS diagnosis. It's a very popular support group, so there is a waiting list for the support group, but they do tend to focus on the specific needs of people with FTD and ALS, and it's a very specific needs for this particular group.
Okay, right. And one more. Have you heard of hiding under blankets or constantly itching being symptoms?
Obsessive compulsive behavior in FTD is a symptom. So constantly itching, you always want to check it out and see why they're constantly itching. We always want to seek medical attention and see, is there something physical that's happening, which is causing something to happen? They may have a rash. There may be something else going on, which is causing the constant scratching. There may be something under the skin that might be a nerve. There might be a nerve burning thing going on. You really want to talk to the doctor about it. But if the doctor can't see any reason as to why the behavior is occurring, it may just be a compulsive behavior. I recommended trimming the fingernails down as short as you can so they're not scratching their skin and opening up their skin, which could leave them at risk for skin breakdown or infection. And then going under blankets, it might be comforting. There's been a lot of studies when people are anxious, and anxiety is not uncommon with these types of diagnoses, that that pressure of multiple blankets can be very calming and relaxing for people. So it may actually make him feel safer and may make his environment or the person's environment feel smaller, which may help with their anxiety. They just may have come up with a coping mechanism for dealing with what they're feeling.
Thank you. And is there a more mild case of FTD as memory loss, and that won't progress?
We don't normally see memory loss in the beginning stages of FTD. What's really being described as memory loss may be actually impaired executive functioning skills or lack of insight. Memory loss is a very specific thing, but we end up categorizing it into a lot of different types of groups. So I don't know how to completely answer that question because it's kind of dependent on what's actually happening. But I will say that every person with FTD is unique and different. Every person, the way the disease affects the brain, the progression of the disease, it can be different in different people. And so not every person is going to have the same, it's not going to look the same in every person. We have Partners with FTD Advisory Council at AFTD, which is a wonderful group of people who really try to break the stigma of what's happening with an FTD diagnosis. And they've done a couple presentations for us. They're available on YouTube, telling their story and talking about what it was like for them to have a diagnosis. And I've heard people say all the time how much that speaks to them, because when you hear of a diagnosis like FTD, sometimes you think of the absolute worst case scenario, and that's not always people's story. So you really have to take it day by day and realize that today you have today, make the most of today and the most of your moments that you have today. Because we don't know what the future holds, and it may not, your progression may not look like other people's progression. It just may not be what it looks like for you.
Great. Well, I want to thank you, Esther. Thanks for being part of the summit. We really appreciate it. And I want to remind everyone that the next session starts at 2:45, and it's Living with ALS, Sexuality and Intimacy. So we hope to see you there. And Esther, much appreciated. Thank you.
Thank you for having me.